This is the Paediatric Podcast from Health Ed, where we interview leading experts on important topics that can positively help your practice.
Hello, my name is Rebecca Overton. I'm a practicing GP and I'd like to welcome you all to today's podcast. Today I'll be speaking to Carolyn Pinto and our topic is Understanding Hemispherectomy Brain Surgery in Children. We're going to discuss this surgery, what it is, when it might be performed, the post-operative benefits and impacts, and the Hemispherectomy Foundation Australia. Carolyn Pinto is the secretary of this foundation, which is a peer-led disabled persons organisation that provides peer support, connection and advocacy to families impacted by hemispherectomy brain surgery. Carolyn brings lived experience as the parent of a daughter who acquired chronic focal encephalitis at age 6, requiring hemispherectomy surgery at age 11. Carolyn is also a research associate at the Murdoch Children's Research Institute, where she's involved in research projects focused on topics relevant to children and young people who experience disability following an acquired brain injury. Prior to joining the MCRI, Carolyn had an extensive career in the Victorian Government, specialising in health and human services policy, program design, implementation and management. Carolyn, welcome, and thank you for joining me for today's podcast. Can you tell me a little more about yourself?
Thank you very much, Rebecca, and I'm delighted to be here. Yes, as you indicated in that introduction, I'm the secretary of a small peer-led organisation that supports children, young people and their families that have had hemispherectomy brain surgery. I bring lived experience to the role. My daughter, Freya, had a hemispherectomy at age 11, as you indicated in that introduction, for chronic focal encephalitis. At the time, the foundation didn't exist, and it was very important to us that families who are going through this extraordinary, stressful and traumatic period in the lead up to hemispherectomy have the benefit of connecting with other parents.
Well, this is a very specific and specialised type of surgery. So can you tell me a little bit more about what a hemispherectomy is?
Yes, it is a very specialised surgery, Rebecca, absolutely. So a hemispherectomy is the most invasive and largest of all the epilepsy resective surgery. So that means it takes a lot of brain. And in the case of a hemispherectomy, it is one half or one hemisphere of the brain, hence the term hemispherectomy. So a hemispherectomy is literally the removal or disconnection of one brain hemisphere to treat chronic, intractable and often life-threatening epilepsy in children. So it is not a surgery that is performed lightly, and it is not a common epilepsy surgery, although in saying that it's not uncommon. It is formed in Australia at only 3 paediatric tertiary centres in Sydney and in Melbourne, and we think that there's probably around 2 to 5, sometimes more, hemispherectomies performed at each of those centres each year.
How long has this surgery been performed?
It was actually first performed back in the mid-20th century. They started using hemispherectomy as a way of treating malignancies in the brain, and then I believe it was used as a way to treat chronic epilepsy confined to one brain hemisphere, but outcomes at that time weren't very good. There was high mortality and morbidity, so it was abandoned for a period of time until newer surgical, less invasive, safer surgical techniques arose in the late 1990s, and they continued to evolve in the 21st century. So it is now considered a very safe surgery with low mortality.
But presumably then we don't have patients who had this in childhood who have yet lived to a long age. I'm expecting that the patients who've had it in Australia since the 1990s are probably, in their 40s now?
That's right. And often I refer to our hemispherectomy children and young people because predominantly they are, although we do have members of our foundation that have had surgery that are now in their mid and late 40s.
Okay. And so why is this specialised surgery performed, Carolyn?
Well, it's performed when the epilepsy that the child or the young person is experiencing is intractable. And when we talk about intractable epilepsy in our kids, we're talking about the type of epilepsy where children or young people are experiencing daily seizures. So daily seizures could be a few seizures, it could be dozens, and often it's hundreds. So extraordinarily severe seizure disorders. Often this seizure is called catastrophic epilepsy. So the type of epilepsy that these children are experiencing is really incompatible with functioning and with family life. And so the type of epilepsy that they experience is chronic, it's severe, it's intractable, and it's medication resistant. So most of our children will have trialed 1, 2, maybe up to dozens of anti-epileptic medications and other treatments to control the epilepsy, but it's proved to be medication and treatment resistant. So surgery really is the only option. And because the epilepsy is confined to one brain hemisphere, and often the epilepsy is making that brain hemisphere fire, and often there is a lot of damage in the brain hemisphere which is causing the epilepsy in the first place. If you think about my daughter, she had a form of chronic encephalitis. So it was continued inflammation and in the right hemisphere of her brain, only in the right hemisphere. We don't know why that was the case, but that is the case with the type of encephalitis that she contracted. And so whenever that inflammation would occur, it would cause epilepsy, it would cause scarring, and is at the point where most of her right hemisphere was becoming atrophied and scarred. And we find that with a lot of our children and young people that are candidates for hemispherectomy, that their affected hemisphere is very badly damaged, either congenitally, there's been damage, or in acquired etiologies like my daughter with her encephalitis, that hemisphere is really not good for very much other than producing this extreme life-threatening epilepsy.
So you've mentioned some of the brain conditions that might lead to a hemispherectomy, such as sort of chronic intractable or catastrophic seizures and encephalitis. Are there any other brain conditions that might lead to consideration of such a significant surgery?
Yeah, there's quite a few, Rebecca. The ones that we most see in the children and families that join our foundation are intrautero strokes. So the baby has a stroke in utero, and there's considerable damage to one brain hemisphere, and that's often not diagnosed until birth or shortly after birth. The mum mentions, she says, I thought I had a very hiccupy baby in utero. The baby wasn't hiccuping, the baby was seizing. So as soon as the baby is born, they realise that there's seizure activity there. They do the MRI and they see one brain hemisphere that is extraordinarily damaged by intrautero stroke. So that's one of the more common reasons for hemispherectomy. We get congenital conditions. One is called hemimegaencephaly, where one brain hemisphere fails to develop properly. So again, it's not a functional brain hemisphere. And really, again, as I said, with some of the other conditions, that hemisphere is doing more damage than good. It's not functional. It's producing seizures. Often those seizures flow through to the good hemisphere of the brain. So the decision is made for those children where that brain hemisphere is not functional, it's seizing, and that epilepsy is usually confined to that one brain hemisphere, although you can get activity going across to the good hemisphere as well when that seizing is so frequent that we call it a kindling, so that the opposite hemisphere could start kind of copying the behaviour of the seizing hemisphere. But that usually resolves after the hemispherectomy, in which that damaged hemisphere is either disconnected or removed.
And at what sort of ages can this surgery be performed?
We usually say that the earlier in life that surgery is performed is better, because you don't then get the effect of all that detrimental seizure activity on a very young brain. But it's not always possible. My daughter contracted her encephalitis at 6. So you can have surgery done from about the age of 6 weeks right through until we have a young person in our community that had his surgery at 18. So it can depend on a whole range of factors. We do say for the children with congenital conditions that really lead to that very severe epilepsy in infancy. The earlier that surgery can be performed, the better, as long as the baby is at an age and weight that the surgery, because it is a big surgery, it's a long surgery, blood loss is common. So as long as the baby is getting to around that kind of 4 kilo weight mark, then surgery will be considered, because the risk of delaying surgeries far outweigh that of undertaking the surgery. And so when you've got that type of catastrophic epilepsy occurring in a young infant, it really does impact the ability of that other hemisphere to develop normally.
Okay. And this is such significant complex surgery because, as I understand it, you're either removing lobes of the brain or severing the corpus callosum. So
Yes.
this is going to have significant long-term physical, cognitive, sensory impacts. Could you talk me through what they might be?
That's exactly right, Rebecca. You do not remove the function of half of the brain without there being significant impacts. So a lot of the impacts will depend on the hemisphere that's removed. Is it the dominant hemisphere? And most people, that are right-handed are left hemisphere dominant. And also depend on the underlying etiology, so the reason for the hemispherectomy being performed. But there are a number of inevitable consequences of hemispherectomy that are given when a child has this surgery. So because the motor cortex of one hemisphere is disconnected or removed, there's going to be a hemiplegia on the opposite side to the body. So most children get pretty good ambulatory function following surgery. So, and particularly the kids that have the surgery performed young, they usually walk, can run, hop, skip, and jump. Upper limb function is more severely affected, and find hand function and finger function on the affected hand is lost. So it's extremely rare for children to regain any functional use of their fingers and hand on the affected side. Arm function does come back to a certain degree. So most kids will use their weak arm as a bit of a helper arm, stabilizing paper or helping to carry something. But it's a significant physical deficit to have that hemiplegia and lose fine hand function. So that's an inevitable consequence of hemispherectomy. Another is hemianopia, which is a loss of vision. It's a loss of central field of vision, and it's a loss of peripheral vision, again, on the affected side. And that's because the visual cortex is, again, either removed or disconnected during a hemispherectomy. So that will mean children have reduced fields of vision, huge impacts for safety, because they often can't see what's happening in their blind fields. Educational impacts are significant too. They need to be able to relearn reading if they were reading prior to surgery. They need to be able to safely navigate their worlds without that peripheral vision. And kids do compensate for the visual loss reasonably well. So, and there are compensatory mechanisms like prism glasses that can help bring in that periphery, but it is still a significant visual loss that children live with, and in most states, it will mean that driving is not possible in adulthood.
And then what about things like their learning performance with reading and their sort of ability to attend a mainstream school?
Yeah. And that's where we really see dependence on the underlying etiology for the surgery. So what we find is that the children that, like my daughter, have a particular type of encephalitis that leads to surgery, and she had a very normal, typically developing childhood. So both sides of her brain got a really good chance to develop normally before she contracted her encephalitis. That cognitively, children that have surgery for this type of encephalitis do the best cognitively, whereas children that have a congenital brain malformation, so their little brains started off not being normal, they tend to have the poorer cognitive outcomes. So amongst our foundation, amongst the kids that we have got, you will just see that really diverse spectrum of cognitive outcomes. You will have children with quite significant intellectual disability. You will see children with mild intellectual disability, and you will see children with no intellectual disability. And it's very, very hard to generalize because of that diversity of outcomes and that dependence on what that underlying etiology is. And of course, there's data to say, well, if children had a stroke preoperatively, this is going to be their likely outcome, cognitive. But of course, there's outliers to that. And so we have kids that attend specialist schools. We have kids that attend mainstream schools, and we have children that have had successful tertiary education and are now in full-time employment. So it's very, very hard to generalize. So they do say that there is a correlation between age. Obviously, younger age is better when the brain is more plastic, and that remaining hemisphere has greater potential to pick up those functions that are lost when the damaged hemisphere is removed, and the length of time the child has seizures before having the surgery. So that's a real key takeaway message, that shorter duration of epilepsy is correlated generally with better outcomes because seizures do damage, and intractable epilepsy does damage. And being on 1, 2, 6, 7, 8 anti-epileptic drugs is not great for a child's brain. Each one of those drugs has an impact. It has an impact on cognition and behaviour and learning and social participation. So really, we're very much of the faster pathways to surgical evaluation for children that do have intractable epilepsy that could benefit from hemispherectomy surgery.
And you've mentioned that intractable epilepsy is one of the commonest reasons that a child would undergo this sort of surgery. So what are the expected outcomes of hemispherectomy in terms of things such as seizure control and also, say, quality of life for the patient and for their family?
Well, it's seizure control and better quality of life for the child and their family is what this surgery is all about. Bringing those, either eliminating or significantly reducing seizure burden in the child. So we know for about 70% of our of children that have the surgery, they'll be seizure free after surgery. Most of our families will say the last seizure that my child had was the one while they were being wheeled into surgery. Such is the seizure burden that the child has, is that they're seizing all the time. So that's the last time I saw my daughter have a seizure, was on that gurney as she was being rolled into the operating theatre. But again, it does depend on underlying etiology and the reason for the hemispherectomy, because when there is significant brain malformation, often seizures will remain, or whether there's some impact on that good hemisphere as well. There might be, a few things happening on that side as well. But we do know for most children, they will either be, and about 70% will be seizure free, and the remaining proportion will have a significant reduction in their seizure burden. So they'll go from having possibly dozens or hundreds of seizures today to something that is far, far more manageable. So the impacts on quality of life are obvious. There is no family function, child function when a child is living with that level of epilepsy, and the educational, social impacts are monumental. A child can't attend school. My daughter hadn't attended school for months before she had her surgery. The social impacts of epilepsy are significant. The social exclusion that occurs. Economic impacts on the family, for example, when I had to become the primary caregiver for my daughter, and we know that's really common amongst our families of kids with severe epilepsy leading up to their surgery. It's just not compatible with functional family life. Sibling impacts are huge. The trauma of parents and siblings and the child themselves having that level of epilepsy is huge. So what we see when that epilepsy is removed, and yes, the child goes on to live with lifelong disability, but does that disability compare with the disability that's imposed by intractable epilepsy? So I haven't heard any family say to me, I regret having agreed to a hemispherectomy for my child, because the quality of life is just so much greater. And today, my daughter, she graduated from her secondary school and university, and she lives independently and she works full time. If she hadn't had her hemispherectomy, I don't think we would have her now. Such was the nature of her epilepsy. But if she had, her quality of life had not had the surgery, we believe the quality of her life would have been very, very poor, because her cognition would have continued to decline. And that's what happens with intractable epilepsy. It continues to create that cognitive decline. So a hemispherectomy will prevent that. It will prevent that, because that young developing brain isn't continually being impacted by the effect of cognition, the cognitive effects of uncontrolled epilepsy, and not to mention the impacts of all those anti-epileptic drugs. And our kids are often on industrial doses of those drugs, which have impacts, as I think I mentioned earlier, on cognition, on behaviour, and obviously the ability to participate in their education and community and social lives.
Thank you for sharing that story about Freya, your daughter. And it's just so wonderful to hear that she's graduated high school and university and is living independently, working full time.
Yes.
I think that really speaks to how important this surgery is. But as you mentioned, these kids post-operatively can have complex health needs if they have a hemiplegia, hemianopia. There's educational, cognitive, intellectual impacts. So how could GPs best support children and families sort of in the months and years after they've embarked on this quite profound surgery?
Yeah, it's really important, Rebecca. Most children will, after hemispherectomy, will undergo a period of intensive inpatient rehabilitation. So, a lot of kids, like my daughter, will need to relearn to walk after surgery. They will need to be able to learn how to navigate, their daily care with the use of one hand. If they're dominant hemisphere has been affected and they've had language loss, they'll need intensive speech therapy to support language recovery. So all children do tend to have quite an intensive period of inpatient rehabilitation at a dedicated paediatric rehabilitation service. I say most because not all do. But particularly for our regional and rural families, they will often then go home and their care will be provided in a primary setting. So it's really important for GPs to know that, yes, the hemispherectomy may cure the child of their seizures, but these children are very neurologically complex children. So there's a number of things that require lifelong vigilance. So neurologically, even if they've had the most minimally invasive resective hemispherectomy technique, there will still be sections of that hemisphere that have been removed. So that puts hemispherectomy children at greater risk of complications like hydrocephalus. So we always tell our families that vigilance around hydrocephalus is lifelong. So if a child that's had a hemispherectomy presents to you with, symptoms that you might think align with, a viral infection or in another child, something gastrointestinal, headaches and vomiting and loss of balance, you've got to think hydrocephalus for our kids, and make a referral for further investigations. So the other aspect of our children that requires lifelong vigilance is their physical health. They will be very much prone to spasticity in their affected limbs, which will often require interventions such as Botox to release that spasticity in their affected usually upper limbs, often lower limbs as well. But often it gets to the point where that kind of Botox is no longer working and the muscles build resistance to it. So there will be surgical interventions such as tendon lengthening in calves and in forearms. There might be some tendon cutting and wrist fusions, because children are very prone to contractures in their affected hands and fingers that aesthetically look very unappealing. They make that child look very different from their peers, and they become very uncomfortable and often painful. Implications for hygiene, for example, for washing a hand that's heavily contracted. So it's really important that GPs are vigilant about looking out for contractures in a child that does have a hemiplegia, and a child that's had a hemiplegia as a result of a hemispherectomy will have that dense hemiplegia that's more prone to these type of things. They can get subluxations in their hips and in their shoulders. That's quite common because of the hemiplegia. Again, because they're much more dominant on their stronger side, they can get things happening like, bursitis because of that imbalance of their limbs. So be conscious and be vigilant about the physical impacts of a hemiplegia, and if they're treating other children, hemiplegic cerebral palsy, for example, that will be the kind of interventions and vigilance that our children need is very similar to those children that might have dense hemiplegias from other conditions.
And I guess in terms of optimising their academic outcomes at school, I guess checking that their hearing's normal and, preserving vision because they have had visual compromise.
Yeah, and that's a really good point, Rebecca, about what you say about hearing for our children, because hearing per se is not affected by hemispherectomy, so they'll pass hearing tests no problem. But what we find is that because of their neuro reorganization and the impact on the deeper cortical structures, that many of our kids will experience cortical auditory disorders. So they can hear fine, but put them in a crowded, noisy classroom, which most classrooms are, and they'll really struggle with discerning sounds and where it's coming from, and that ability to really block out that kind of background noise. Now, that's not universal to children that have hemispherectomy. Lots of kids can experience that type of auditory processing challenges, but for our kids, it has that neurological basis. So it's something that educators really need to be careful and vigilant about, that while the child might appear to hear normally, as soon as you put all those kind of competing sounds together, things become much, much more difficult for them, and their learning will be impacted if they don't get that type of instruction provided in a quiet environment and in a way that can be well understood by the child or young person.
Now, earlier on you mentioned that this sort of surgeries takes place in sort of 3 tertiary paediatric centres in Australia, and probably only up to 5 times per year at each of those centres. So we're talking about possibly 15 young people in Australia per year who might actually undergo a hemispherectomy surgery. So many GPs will never meet a patient or a family who's undergone this surgery. But I think it's still important that we understand some of the important messages around why it might be performed and some of the long-term outcomes. So what important messages would you like GPs to understand so that we can best support these young people and their families?
I think I've touched on a few of the key messages that I'd really want GPs to understand, and you're quite right. Many GPs will never have come across a child or young person that's had this surgery, or if they do, it will be an uncommon experience for them. But for them to realise just the neurological complexity of our children and that vigilance, that constant vigilance for anything that might indicate a neurological issue, and to refer on. As neurologically complex as our children are, many of them after surgery and after they leave that kind of tertiary level care won't have an ongoing neurologist. So their primary care physician might be it. So be conscious of the neurological complexity of hemispherectomy children. Be vigilant to those kind of to the physical impacts of surgery, and monitoring for those symptoms that might require an intervention, an orthopedic intervention or a plastics intervention, and refer on before things become chronic. It is much easier for a surgeon to make a contracted hand and arm better when the contractures aren't at the point where the arm and hand are completely turned in, and you're looking at breaking bones and doing a much more difficult and painful surgery for the child. Be conscious of the mental health impacts on child, parents, carers, and siblings. I think after surgery, there's a sense that everything's going to be fine, and often it is, but be very conscious that these families and children have undergone an enormous trauma. There will be medical trauma that the children have experienced. There will be trauma that siblings and parents have experienced through witnessing uncontrolled epilepsy over months and in often cases years. That leaves scars. Post-traumatic stress disorder is real. It's real. It took probably 3 years before, whenever I heard of a crash or a bump in my house, I didn't automatically think my daughter was having a seizure. So that kind of post-traumatic stress is real for our families. So understand the impacts of that on the mental health of the parents that you're seeing and the child or young people that you're seeing, and support that mental health however you can. Understand too that many of our families will have children with intellectual disability. And again, the mental health impacts of working with a family of a child and the grief that family experiences, where they know the outcome for their child is not going to be the same as the best outcomes of some young people that have had hemispherectomy, or the outcomes of their friends and other family members. That takes a huge mental toll. So GPs really need to be aware of that and screen for mental health issues. Where you really identify that could be an issue. Understand that transition from paediatric care to adult care is a mammoth issue for our families. Everyone describes it, in the sense of falling off a cliff. Often, and particularly our metropolitan families, they're getting this multidisciplinary care at a tertiary centre, for many, many years. And that stops. That stops when the child leaves paediatric care, where families are left to kind of hobble together their own specialist arrangements that were consolidated for them in their paediatric centre. Many of our regional and rural families will have to do it before that point, but a lot of our metropolitan families will have had that multidisciplinary care provided for a long time. And so GPs at that point of contact, need to be that point of contact where they need to make those referrals for that family and to be their main point of care person. And just understand that leaving paediatric care for those families that have had that long experience, it's difficult, it's challenging, and again, it can feel like a huge juncture and challenge for families with significant mental health impacts as well.
And then before we finish, Carolyn, can you tell me a little more about the Hemispherectomy Foundation of Australia?
Well, we've been around a little while now, Rebecca. We formed as a charity back in 2013, and that was spearheaded by a Sydney mum, Karen White. Her son had to have a hemispherectomy. He was only little. He was about 4 years old. She described her experiences like being on the moon. She felt so isolated from everyone. There was not another family that she could speak to. Her experience was so isolating, and you can understand that when you were told as a parent that the only option for your child is to have half their brain removed, it's traumatic, it's confronting. Some of our parents will say, that's Frankenstein medicine. You won't be doing that to my child. It's an extraordinarily difficult concept for parents to have to understand and, in many cases, ultimately accept. So it was so important that to Karen that no other family walked that journey alone. We felt very much the same. We would have felt so much better had we been connected to another family earlier in that journey towards hemispherectomy for our daughter. So it's about allowing those connections to take place, providing a safe place for connection and support, providing lived experience guidance, lived experience information. We don't take the place of clinical information, and we will never seek to do that. But we work closely with the hospitals so that families that are looking like needing a hemispherectomy for their child know about us, and they can reach out to us at a point that when they're ready to, whether that's before surgery, after surgery.
Well, Carolyn Pinto, thank you so much for joining me on today's paediatric podcast and for sharing your expertise and insights as well as your lived experience about this very important topic. And as we mentioned, GPs may not meet these young people and their families very often in a career in general practice, but it's just so important that we have a greater understanding about why this surgery might be performed and some of the impacts from the surgery and how we can best support these young people and their families. So thank you again for joining me today.
Thanks, Rebecca. Thanks so much for your time.
If you are an Australian healthcare professional and enjoyed listening to this episode, you can claim CPD points by creating a free Health Ed account. Visit healthed.com.au and claim today.